Dear colleagues, I would like to welcome you all to this symposium sponsored by Novartis. The topic we are having the lecture on today is one of the very important topics facing us all in our practice. The lecture will be about the evidence-based medicine in the management of diabetic macular edema. The speaker is our very well distinguished speaker, Dr. Ahmed Al-Barqi. Dr. Ahmed is a veterinary consultant in Sheikh Khalifa Medical City, and he has a very vast experience in the management of diabetic macular edema. Please, Dr. Ahmed.
Okay, thank you, Dr. Muhammad, for this nice introduction, and I want to thank Novartis for inviting me today to talk today about your symposium. My talk today, actually, I will try to show some evidence-based data about the management of DME. So, my main point today, we are going about the management objective, or when dealing with the case of DME, pathogenesis and treatment options we have, and finally the efficacy and the safety of these treatment modalities. So if you start with the management objective of DME, first of all, I think the main objective is to reduce the rate of disease progression on visual loss, and I think glycemic control or or glucose control play a role at that point or that stage. Second objective is to stabilize the vision, and laser might have a role at this stage, and the most important for sure is to improve the visual loss. And here came the role of intravitreal pharmacotherapy. And another important point, which will be actually my main or the core of my presentation, is that to maintain the visual gain we have achieved from the treatment. And here, the treatment regimen I'm going to follow play an important role at that stage. So generally speaking, the treatment goals is to improve and to maintain the visual acuity, and also to achieve optimal glycemic control, because it's helped us during the treatment course of the disease. So there's important actually a trial. It shows how can the DME be a predictor for a vascular morbidity and mortality. Okay, so we can see here, the diabetic patient who has DME have a higher risk compared to those without diabetic hypertension to achieve or to get high risk to get cerebrovascular accident or acute myocardial infarction. So when dealing with the case of DME, this is a predictor that patient at a high risk to get any cerebrovascular accident. So it needs to be controlled and need to be in conjunction with the endocrinologist or internal medicine physician. Talking about the pathogenesis, actually, I think DME actually is a problem. It's multifactorial, and it's a complex issue because, simply speaking, this problem, although it's a one problem, it's respond to the laser treatment to some extent, respond to the intravitreal steroid, respond to intravitreal anti-VEGF, respond to vitrectomy in some cases. So one problem which respond to different treatment modality with completely different mechanism of action. This reflects how complex or multifactorial of this disease. So, but we all know or agree that the sustained hyperglycemia, the main risk factor, which might lead to breakdown of blood-retinal barrier, and finally leads to edema. This is a well-known, and we see it in our practice. So, we all know about this. Also, I go through this fast because we have microvascular occlusion and microvascular leakage. And the main point here is the number of pericyte or loss of pericyte, which some trial showed that apoptosis may be responsible for that. And they found that the stimulus for this apoptosis is the fluctuating level of blood sugar. This may be a stimulus for apoptosis to decrease number of loss or to lead to loss of pericytes. This is a nice actually slide by Trypsin Digest, show that in normal capillary, we have one pericyte per each endothelial cells, while in diabetic patients, we can these loss of pericyte, or at least the pericyte become necrotic and non-functioning. So this algorithm actually shows us the role of VEGF-A specifically in the pathophysiology of the DME. So we have chronic hyperglycemia leads to inflammation, ischemia, loss of birth, as we said, and this leads to increase in the level of the VEGF. Normally we have VEGF. The problem is not with the EGF itself, it's a problem with the overexpression or increase the concentration of VEGF. From that point, the problem came. So this VEGF increase in concentration leads to a problem with the permeability and neovascularizations, and finally leads to leakage and macular edema, which leads to visual loss due to the unfunctionality of the photoreceptor cells in the retina. So just a hint about the VEGF-A in DME. We know that we all have sure data from the trial that the level of VEGF-A in the vitreous on the diabetic patients is much more higher, and overexpression of the VEGF have a certain consequences of the retinal capillaries, leading to, at the end, to the macular edema and neovascularization in severe cases in BDR. So talking about the current treatment management. So here I want to highlight the systemic control, or systemic treatment is very important because we have to know that DME, it's not a disease. It is just a sign or complication of the diabetes. So while dealing with the case of DME, you should always remember that the main disease is diabetes. So control of the diabetes will have good impact about the final visual outcome. So talk about fastly about the systemic treatment we have. We found many trials about the glucose control, and also blood pressure control have a good effects. And finally, we have the field trial, which uses fenofibrate to lipid control. It's found to have a good impact about the reduction in the progression of the disease. So now about ocular treatments. We have all know that the main options we have in our hands is the laser treatment and intravitreal pharmacotherapy, either steroid or anti-VEGF, and finally vitrectomy. I'll just go through the vitrectomy because it's not our main concern today, just to show the indication when we can do vitrectomy. If we have vitreomacular traction, for sure, specifically the anteposterior traction, toward posterior hyaloid, epiretinal membrane, and some cases of refractory macular edema. So in this case, for example, we have traction. So I believe in this patient, if you try anti-VEGF or laser, it will not help. Another case, that's the example, we have post-anteroposterior traction together with epiretinal membrane. So I believe this patient will not be a good candidate for medical treatment or laser treatment. So going back to the main aim of our trial today, what is the role of laser in DME? Actually, previously, for sure, according to the trial from the early treatment diabetic retinopathy trial, ETDRS, it showed that focal or grid laser was the standard of treatment in DME. But for example, for this case, or this patient, actually the laser stabilized the vision. It's not improving too much, but later on, after 4 years, the patient starts to lose vision. And this is one of the unmet medical needs in laser treatment. We're going to discuss this later on. I'll just note that the main aim of treatment, actually laser, we all know, is just to stabilize the vision. It's not our aim to improve the vision by using laser in DME. And so the limitation of treatment, as I told you, the improvement is uncommon, and most of the patients lose vision by time, and we will show this later in this presentation. We have knows about the complication of diabetes, and of the laser, but actually now we have a micropulse laser. It might be beneficial, it could have a good impact, but actually it needs multicentral head-to-head trial, because as you know, most of the laser used of the common trial, either on other anti-VEGF or steroid, it was conventional laser. It was not micropulse. So we are waiting for some more data to reflect if the micropulse can behave differently than the conventional one. So what about the steroid? We all know that we have some option in steroid. We have intravitreal triamcinolone, but I don't believe that it was used now after the introduction of steroid implant like dexamethasone and diflunisone. But the problem with this steroid, we know it's improved vision for sure and decrease the macular edema, but it has common side effects and well documented about the intraocular pressure and cataract. And also, if you look at the trial, it showed that the efficacy or the duration of action of implant, it will not last for 6 months. It lasts maximum to 3 to 4 months. So we have to repeat it again. Just to show at some trial or most common trial about steroid, so we have the most common, the FAME trial with formoterol and ME trial with Ozurdex. And you can see here the incidence of cataract and high IOP was a little bit high. And for me, this actually restricts the use of steroid as a primary or a first line of treatment in DME. So now we got the role of anti-VEGF therapy. As I told you, we have two main unmet medical needs with laser treatment. The first one, as I told you, laser does not improve vision, mostly, in most of patients, and many people lose vision despite the treatment. And we're going to show some evidence to support this. We'll start first, laser does not improve vision. Let's have some evidence about that. So if you go to the RESTORE trial, we'll find here that the patient who received only laser during the first year, if you look at the visual outcome at the 12 month, it's incomparable, actually. The laser does not improve the vision at all. You can say it's far, far away. The ranibizumab or anti-VEGF is the effect of visual acuity, the gain was much more higher with ranibizumab compared to the laser treatment. Another evidence from DR-CRNet, also the same. You can see here that the laser, either with prompt or the failed laser, gain visual acuity very high compared to the laser alone or triamcinolone with prompt laser. Another evidence also from the VIVID and VISTA trial with aflibercept had the same. The gain was much more higher with aflibercept compared to laser. The second point or the second issue is the many patients lose vision despite laser. So we got some data also from RESTORE. We can see here that almost 13% of patients lose more than 10 letters, and almost 9 or 8.5% lose more than 15 letters compared to the ranibizumab alone or ranibizumab with laser. Another proof or evidence from DR-CRNet, the same, same behavior. The previous slide was a patient who lose more than 10 letters. This also shows how the patient who lose more than 15 letters, still the laser patient or the patient who got laser lose more vision compared to the ranibizumab. Also, another evidence from VIVID and VISTA for aflibercept, we can see clearly here that those who lose more than 15 letters was almost 10% in laser group in VIVID and 9.1 in VISTA compared to the aflibercept. So this is just to compromise the whole trial together. So most of the trial, or the most common trial while following the guidelines, show that the laser does not improve vision. Also show that the patient with laser lose vision despite laser. So an important question, does the type of the macular edema differ or matter? Is it focal or diffuse if you use laser for that or not? So if you look for evidence for that, you can see here from DR-CRNet 1 year result, you can see that patients who was predominantly focal or diffuse, still the ranibizumab have a higher visual gain compared to the laser group, either focal or diffuse. At 2 year laser, you can see the same behavior. Still, the laser does not do well, and interestingly here, the laser still does well in focal macular edema compared to ranibizumab. Also, another evidence from the RESTORE trial also does not make any difference. Still, the ranibizumab do more or better than laser, regardless the type of the macular edema, is it focal or diffuse. Another issue, if you're going to use laser with the ranibizumab or anti-VEGF, which one is better? Prompt laser, which is done within a week, or deferred laser, which we done more than 24 weeks. The result actually of DR-CRNet showed that the patient with deferred laser actually gain almost 3 letters at the end compared to the ranibizumab with prompt laser. So this data showed that the deferred laser actually is better than prompt laser. So talking now about anti-VEGF and DME, which is the main. So we're going to discuss briefly the structural difference between different anti-VEGF and the treatment of DME, efficacy, treatment regimen, and safety. If you start, I thought most of you all now knows about this slide. This has been shown in many presentations. But just to remind you about the difference in ranibizumab after bevacizumab, here we're going to have anti-VEGF. It's a Fab fragment. It's target all VEGF-A. Aflibercept is a recombinant fusion protein which target all VEGF-A, VEGF-B, and placental growth factor. And it have a FC portion. Here, ranibizumab, it's a full-length antibody, actually. And for sure, it's different in size and different in molecular structure. So talking about the efficacy of anti-VEGF. Sorry for this busy slide, but it just shows us that in all trials, either with Lucentis and Vivid Vista for aflibercept, all evidence supporting the efficacy of anti-VEGF in the treatment of DME. So they are all effective, and we have results supporting or prove that. And again, I just remind you that all these studies also have shown that the laser is superior, the anti-VEGF is superior by far to the laser treatment. So this is the main point actually that I want to focus today about, which is the treatment regimen for DME. If we are talking about the treatment regimen for DME, actually, we should look for what's our target when you are going to treat a DME patient. What's your target from, regardless of the treatment regimen you're going to follow? Actually, we have some objective or target. First one is to, and that's very important, it's not the problem is to gain or to improve the vision. I think the most important issue is to maintain this gain. And you should follow the treatment regimen that give you this, to gain and maintain. Because the point here, if we have a patient and the treatment with whatever the treatment, whatever the agent you are going to use, and this patient has edema, and you give injection and the edema resolved, and another month it recur again, and then give again, and it will. This kind, we call it this causes some sort of retinal stress, because recurrent edema actually, it will cause this kind of retinal stress, which leads at the end to affect the functionality of the photoreceptor layer of the retina. So it's not optimal actually to just treat. The optimum is to achieve dry macula and maintain this gain. So this is a very important objective for treatment regimen. Another one is definitely we have to avoid as much as we can under or over treatment. The last thing, if you can use this number of injection, it will be perfect. So we have actually two main regimen actually. We have fixed dosing, like we see in monthly, Rise and Ride, or in Vivid Vista 5 loading dose bi-monthly. Treat and extend, the same, but with less number of visits. And what we are going to talk about is the flexible or individualized dosing. I think this is the most appropriate, for my mind, the treatment option we can have. And we get the data from the Restore extension with ranibizumab. So if you're going to initiate the treatment, the idea actually is to give injection monthly until you reach what we call maximum visual acuity or stable visual acuity for 3 months, 3 consecutive reading. Just to show here, for example, so we give injection monthly until we reach 3 consecutive stable reading regarding visual acuity on a monthly basis, and then at that time we can follow up the patient on a monthly. If we are, and this, as I told you, the data from here came from the Restore extension. If the patient, when to initiate retreatment, we go talk about initiation now, but if during the follow-up, the patient start to lose vision again or macular recur. So the idea is to do the same, actually, to keep injecting the patient monthly basis until you reach 3 consecutive. For example, here, the patient, the visual acuity dropped, so you start injection until you reach 3 consecutive stable reading, and then continue to follow up the patient. And by the way, the number of injection at this Restore extension at the end, most of the patient actually does not require almost 2 injections, I think, in the year 3. So this reflects, if you maintain the gain you've got, you will have to use less number of injections. The number of injections will be less. So regarding the safety, actually, during the whole trial, regarding the Lucentis or ranibizumab and also aflibercept, there was found there is the incidence of ocular or non-ocular or systemic side effect almost similar across the whole group. So we don't have actually a solid or pure or confirmed data say that we have a systemic problem with this disease. We all know that the drug reaches systemic circulation definitely, but this is the level of concentration of the drug reaches systemic circulation can cause really a vascular or cerebrovascular accident or systemic side effect. We don't have a pure or confirmed answer for that according to the data from the multi-center trial. This is the last section of my topic, and because we have waiting for lunch, I believe. So there are some questions actually about the anti-VEGF specifically treatment. It came from the clinical practice. Actually, early treatment, if you treat the patient early, does it matter on the long run follow-up or the long-term follow-up? The evidence, actually, if you get the evidence from RESTORE trial, this patient, for example, this is the laser arm. This patient received laser only until month 12. The other group received Lucentis from the first month. If you look at the extension phase, you will find that you can look here, the patient who received delayed or early or delayed receiving the treatment, the gain at the end of the trial the visual gain was a little bit less compared to those Derazumab alone who received the treatment early. And this actually reminds me with the CRUISE and BRAVO trial with RVO. That's the same patient who received treatment early gain or achieve a visual gain more than those who delayed the treatment. So it seemed to be, it's a common golden rule actually, golden rule, to treat earlier, you get the best result. Another action, while dealing with a DME patient, is there any predictors that can tell you this patient will gain more than the other? Actually, we have some data from DRCRNet and RESTORE trial. It showed that the baseline visual acuity is very important. The baseline visual acuity, if it is more, less, or poorer, the vision will subject to gain more vision. Another thing is the central retinal thickness. Also, if it is markedly increased or greater, we expect this patient to have more or better visual gain. Another thing is older age and shorter duration, this is a matching, as I told before, the early treatment. So we shouldn't wait for the patient. Once we diagnose the macular edema, we should treat it as early as possible to get a better visual outcome at the end. And this is some data proof from the RESTORE trial. You can see the patient who have poorer vision gain more visual acuity compared with those who start with a better visual acuity. Regarding the central retinal thickness or macular thickness, also patient who has or more thick retina or macula, sorry, it gets more visual gain. What if the patient had prior laser? If the patient had prior laser, does it affect the final outcome or does it affect our clinical practice? Let's see about this. We have data from RESTORE also that the patient who received laser before or did not receive laser before, still the visual benefit were consistent in both group. So it will not affect. And this actually reflects also the limited rule now of laser alone in the treatment of DME. Another, so from the DRCRNet, also the same. Patient who didn't receive laser behaved the same to whom we didn't receive any laser treatment. This reflected the importance of the efficacy or the efficiency with anti-VEGF treatment. This is another important debatable question, actually, but do you still need FFA in the treatment of macular edema after the introduction of OCT, and now we have spectral domain, and it's coming the new generation with adaptive optic? Actually, I think, yes, we still need fluorescein angiography, definitely, because this is the only way to exclude macular or ischemic maculopathy. We don't have other option or other tool to help us to discover that. And definitely, ischemic diabetic or ischemic maculopathy has a different behavior or different prognosis rather than non-ischemic. As we see in this photo, you will never see this in OCT. You might find some atrophy or atrophic changes at the level of the RPE or photoreceptor, but you cannot sure if this is ischemia or not. Another indication or another point, if we need a supplement laser, it's better actually to use some fluorescein to know exactly where the area of the capillary dropout, so we can target it with laser, rather than doing the laser in a matter that it will not help you. So if you target only this area of capillary dropout, it will be more beneficial. Another thing for sure, if you have poor responder to the anti-VEGF or steroid, we have to try laser. And a very important point here I want to show is the peripheral ischemia, because some patients with severe or even moderate number of diabetic retinopathy with a lot of cotton wool spots, this patient might have some peripheral ischemia and does not respond well to the treatment. But so if you do some scatter laser at the periphery, I think this will help in the treatment, and it will aid the treatment, other anti-VEGF or whatever. It will help you more to gain more visual acuity. So peripheral ischemia actually is one of the most important issues. Some people forget about it. So after all that, after I mentioned that the laser now, the rule of laser really has been challenged a lot, but after introduction of anti-VEGF or intravitreal pharmacotherapy, but do you still have a rule for laser in DME? Definitely we still have some rule, but it's not common actually, but we still have like some non-central involving DME. We have focal leakage away from the fovea. We still, without not involving the laser, we can use some few shots of laser, it will help. Also, as I told you, supplementary with anti-VEGF, but we prefer the deferred laser, not the prompt one. Again, the poor responder, as I told you, and the peripheral ischemia. Like this case, for example, this patient have, if you can see here, he has just an exudate, cercinate exudate here, and the ONCT, you can find the thickness, the thickening is away from the fovea, and it's not involving the center. So I believe this patient might get benefit from some few scatter laser or focal laser about targeting this area. What is the role of steroid? Steroid, yeah, for sure. I think this is a debatable issue because some doctors use it as the first line of treatment, some don't use it other, but anyway, those who use it, who use the anti-VEGF as the first line of treatment, if you have a poor response or you can try or switch to the steroid. Pseudophakia is another indication. A few data actually coming now about combining the steroid with anti-VEGF, but still the data is not mature enough to comment on it. The last thing, this is a very important, if you have a patient who is cataractus with maculopathy and he's going to do surgery, this is an indication I can say for the steroid, because we all know that phaco or cataract surgery, we cause what we call surgical trauma with release of more prostaglandins and inflammatory mediator. And for sure, we know that the steroid work better on the inflammation and prostaglandin rather than the anti-VEGF. So we can combine, if we have a combined case, we can combine with steroid, or other option is to give injection before the surgery, but still the surgical trauma or the release of prostaglandin is still there. So it could be an indication for steroid actually. The last thing, which is about the systemic safety. If this patient actually developed stroke or MI recently, this will affect the choice of the. This is a debatable issue actually, and I've attended many meetings about that, and I found that some retinal specialist does not care at all about the history of the if the patient have a recent history of cerebrovascular accident or not, and other are a little bit cautious, but. Yeah, because we all know that this drug reaches systemic saturation, but as I said before, we don't have a solid data to say that this level of concentration in the systemic circulation can lead actually to cerebrovascular stroke or any systemic side effect. So this is, as I told you, all the trials show that there is no difference in the systemic safety among even with the laser group. So this is a bit of a point actually, but for me actually, I will not give the I will not use the anti-VEGF if the patient have a recent stroke within a month. But if more than this, I might think, because usually according to the pharmacokinetic of the drug, it stay in the circulation maximum 3 to 4 days. Generally speaking about the anti-VEGF, or sometimes if you use Avastin, it will stay longer, but not more than a month. So after 1 month, you are sure that the level of the systemic circulation, the systemic concentration of this drug is washed out, and you can use it safely. Other option, you can use steroid at that point. So conclusion, to conclude and this is the last slide, because I know we are running out of time, or we still have. Lunches, I think we are about to be. Anyway, just to remind you that DME is a multifactorial problem. Management should be actually tailored or individualized according to the patient. And actually, we are sure now the efficacy of the anti-VEGF in the treatment of DME. It's well proved by many trials. Gain and maintain, I want to remind you again that not the problem is to, or the target is to gain, it's to gain and maintain the visual acuity is the most important. Another issue, the problem of under-treatment. If you choose a different, or you should be sure that your treatment regimen are going to follow. Avoid under-treatment, which is a common problem, especially in the first year of the treatment. Another thing that I told you, the baseline visual acuity and the central retinal thickness is an important point to predict the visual acuity. So when you are going to cross-trial comparison, we should look at the inclusion criteria, the visual acuity, baseline visual acuity, the CR, the central retinal thickness, the level of diabetes, all kinds. So we shouldn't actually, we should take care of this point, because when you cannot compare trial of result of a trial to other unless if the inclusion criteria is near to each other. Otherwise, if you want to have a proof or a conclusion, you have to make head-to-head trial. Early treatment, as I told you, the last thing is the early treatment with anti-VEGF definitely give us a sustained visual gain. And this is my last slide before I thank you for your attention, and I hope I didn't exceed my time. Thank you.
Thank you, Dr. Ahmed, for this very informative lecture. And thank you for the questions. You've almost answered all the questions in the minds of everyone. Still, sure.
Thank you.
Always you are presenting this way.
Thank you.
So the thing is that you mentioned that there is a chance for fluorescein, or still there is a chance for fluorescein.
Sure.
But you didn't mention when.
As I told you, when if you are treating,
Mention exactly when we can do it. Or
Usually-
we should do it.
it's not should or not. It depends on your clinical experience for
Yeah.
sure. But definitely, when I'm trying to, if the patient has diabetic macular edema without
Yeah.
any other signs of
Okay.
severe or non-bereft diabetic retinopathy, cotomolar spots, I will count only on OCT.
Yeah.
And when I found the patient does not respond well, and I've kind of see some atrophic change at the level of the RP, at that time, I will do fluorescein angiography to look for any ischemic areas surrounding.
Okay.
Other indication, also if the beginning, if the presentation of the patient is severe non-bereft of diabetic, usually I do fluorescein angiography for those patients looking for peripheral ischemia on those patients. So this is the two main indication. If the clinical picture of the presentation was a little bit aggressive or poor responder.
So how many injections you will give that patient, and then you will say that, well, there's a failure?
Yeah, as I show in the individualized treatment, we give injection monthly until we reach a 3 consecutive stable reading.
That's right.
So this means if you 3 stable reading, if the patient improve after each injection, it means that 4 injection at least.
4 injections.
To get a 3 consecutive stable reading, you have to give 4 injection, and then you follow up monthly, and that's.
Thank you very much.
Welcome.
One more question. Dr.
Yeah,
Ahmed.
please.
In patients receiving laser, if laser achieves dryness of the macula, why the vision is not paralleling the improvement? What's your explanation for this?
Actually, the laser treatment, you are talking about grid or focal, or regardless. Because I have, for focal treatment, for grid, treatment, the laser, if you are using a conventional one,
Yes.
you will definitely, you are damaging the photoreceptor layer. This is the way the laser works. It damages the photoreceptor layer to avoid the consumption, high oxygen consumption of the retina, so that decrease the level of VEGF. So you are destroying the photoreceptor layer. So with the effect of laser spot, if it is large, it will affect the final visual angle. But yes?
My question now comes, why these patients are still improving with anti-VEGF injection afterwards? So they shouldn't improve. If the photoreceptors are damaged,
there will not be
damage will be
improvement.
permanent. So
Definitely.
they will not even improve with the anti-VEGF injection.
The question is why it does not improve?
Okay, the question, my initial question is why the visual improvement is not paralleling the OCT dryness of the macula?
Functionality of the photoreceptor.
Yes. Okay.
And
It's
also the
understood that
blood supply.
The propagation of heat can damage the further, even beyond the
Also another
visible
issue
spot.
with the ischemia, the blood supply. The blood supply of the retina, if there is ischemic changes, also it will not, some kind, I'm not talking about purely ischemia, but some relative ischemic changes, it will affect, or will not affect, or will not help the vision to be improved And as you said, it will not matching the picture on the OCT.
Yes.
So we have dry OCT, but visual not improved.
It's not improved.
That's the point.
And why do these patients, as proven by the RESTORE trial, still they can improve after the anti-VEGF injection? Though
yeah, but in this, we don't know actually if this patient have a damage of the photoreceptor or not, because it is the logic. If the patient have a damage, it's not regenerable. If the patient has damage, regardless the cause, it's laser or not, it will not improve with any other of this, any kind of treatment. So those patients who improve, I believe, they don't have any changes, or the functionality of the RPE and the photoreceptor was still there. Might be affected, but not damaged totally, because they improved, but they don't reach the final visual outcome compared for those who receive Lucentis at the beginning. So the point is how much the function of the RPE or photoreceptor specifically work. If it is 50%, 10%, or totally lost. If it is totally lost, no matter we use, even whatever you use, it will not improve the vision.
Okay. Thank you, Dr. Ahmed. Thank you very much, Dr. Ahmed, again.